Good morning, everybody, and welcome to the grand rounds this morning. We have two pieces of good news. We have a phenomenal group of 4 speakers this morning that will address their research interests, and we're looking forward to that. And then, more importantly, perhaps next week you get an hour extra sleep. So there we go. So I'm pleased this morning to be able to introduce each of the speakers, and I'm going to start out with Dr. Kerollos Abdelsayed, who hails from South Valley University Faculty of Medicine in Egypt and has done a phenomenal job as an international scholar in the electrophysiology area and has distinguished himself in that area as author of several papers. And this morning, he's going to speak to us on the impact of leadless versus transvenous pacemaker leads regarding the tricuspid valve impingement. So welcome and come on up.
Yes, yeah. Thank you, Dr. Sharkey, for this great introduction. And good morning, everyone. Thank you for attending today. So I'm, like Dr. Sharkey introduced, I'm Kerollos from the Heart Rhythm Science Center. And today I will be discussing our first analysis of the tricuspid valve dysfunction after leadless compared to transvenous pacemakers. So I have no disclosures. As a quick background, leadless pacemakers emerged as a valuable alternative to the transvenous systems, mainly to avoid the complications associated with transvenous permanent pacemakers. And one of those major complications is tricuspid valve regurgitation observed with the transvenous systems. However, the impact of the leadless systems on the long-term tricuspid valve dysfunction is still conflicting, with some studies showing a high incidence as high as 40%, and other studies showing a lower incidence. So in a previous preliminary analysis that we performed, we did like an analysis on 43 first-time micro-leadless pacemaker patients who had a non-significant baseline tricuspid regurgitation. And as you can see on the figure to the right, we started with people who had normal up to mild or moderate baseline TR and checked their progression within 5 years after implantation. And the definition of new TR worsening in this prelim analysis was at least 2 grades. And this showed a 23.3% incidence of new TR worsening. And if you can see here in the Kaplan-Meier analysis, we observed that the worsening tended to happen later in time, after the first 1.5 years compared to the initial time. However, in both time periods, it was still a significant progression from baseline. What we further did is we analyzed some of the high-quality CT scans for those patients for the location of the device, and we found that there were some devices that were not implanted where they should be implanted during the procedure. So sometimes the device was on the RV free wall, sometimes the device was bridging the RV free wall with the septum. Sometimes we found the device even in the papillary muscles in the subvalvular apparatus. And this encouraged us to expand the sample to our study, which compared the progression of tricuspid valve dysfunction on a large sample of leadless pacemakers and compared this to a propensity-matched sample from the dual-chamber transvenous permanent pacemakers. We also explored the progression in left ventricular dysfunction and measured adverse cardiovascular events. So LEADLESS-TR was a retrospective multi-center study where patients with first-time micro or dual-chamber transvenous permanent pacemakers who were implanted between 2018 to 2022 at one of the 3 Allina healthcare hospitals, so Abbott, United, or Mercy, were recruited. Patients must have a baseline as well as at least 1 follow-up echo within up to 5.5 years after implantation, and they should have up to moderate baseline TR severity, so those with worse than moderate TR were excluded. Patients with history of TR interventions were also excluded. We followed patients up to 5.5 years after implant or censor them at the last clinical encounter, death, pacemaker inactivation, or a tricuspid or mitral valve intervention. So to illustrate this, we started with about 1,209 patients who had the first-time device at Allina Healthcare Systems between 2018 to 2022. We excluded 396 patients for not fulfilling the eligibility criteria, And the remaining 813 patients were divided into the leadless pacemaker system, 241, and 572 transvenous permanent pacemakers. We then propensity matched it based on the baseline confounders, and this left us with about 241 patients in either group. So the propensity score match was performed based on nearest neighbor match, and this was based on age, sex, implant here, and baseline left ventricular ejection fraction. As you can see in the baseline characteristic table, most of the demographic characteristics were matched, but the chronic kidney disease as well as diabetes were higher in the micra, which is kind of expected. Importantly, the follow-up time for both groups was about an average of 2.63 years, but this was slightly longer with leadless pacemakers, about half a year. So our outcomes included our main primary outcome was TR worsening of at least 1 grade, and we graded TR within 4 categories, as you can see in this box. So it was from non-trace all the way up to severe, and we started with the first 3 categories at baseline. The secondary outcomes were left ventricular ejection fraction worsening of more than 10%, as well as major adverse cardiovascular events, which was a composite of cardiac-related mortality or heart failure hospitalization. We then implemented multivariate Cox models to adjust for body mass index, chronic kidney disease, diabetes, and baseline TR. So starting with our first outcome, the TR worsening of at least 1 grade, we couldn't find any significant difference between the 2 devices. The incidence was about 22% with transvenous systems and about 25% with the micro systems, and this was not significant between the 2 devices. Out of the other adjusted factors, diabetes was the only factor to predict the progression after the implantation. As for the ejection fraction worsening of more than 10%, the same results were found, except that we didn't find any of the baseline characteristics here to be associated with worsening in left ventricular ejection fraction post-implant. And finally, for MACE, there was no significant difference between the device again. However, in this, chronic kidney disease and diabetes predicted the progression of major adverse cardiovascular events or the incidence. So before we proceed, it's important to acknowledge and discuss the limitations that we had in a design like this. So first of all, it was a retrospective observation analysis, and although we tried to propensity match for our cohort at baseline as well as adjust for the other confounders when we do the analysis, we were still hit by some inherent bias of indication for the microgroup. The microgroup probably had a higher prevalence of atrial fibrillation as well as a higher or a worse grade of chronic kidney disease requiring dialysis. This is why they are indicated for leadless rather than transvenous systems. They could also have other vascular complications, which makes them slightly or more comorbid group in general than the transvenous systems. And second, we had a relatively small sample size. So although we did our analysis on about 500 patients, but still if we need a high effect size to capture a difference in the lead-related tricuspid regurgitation, we probably were underpowered to do this. We haven't accounted for the improvement in the tricuspid regurgitation. So if we have some people who have a severe TR and then improved with the leadless compared to the transvenous, we did not account for this. It was outside our scope. The leadless pacemakers were followed for slightly longer than transvenous pacemakers. And finally, there could be a potential inter-observer variability due to the difference in echo readings. So in light of those limitations, our comparability to other studies out there, so our incidence was actually lower than what was even reported in other institutions outside and inside the United States in their prelim reports. So the actual question here would be, is it possible to see this type of worsening of TR with leadless systems, even though it's not theoretically possible, since the device is not crossing the valve as in the lead-based systems? And the answer lies in the challenges in the device deployment. So first of all, we use biplane fluoroscopy, which is known to be inaccurate in helping the operator figure out exactly where the location is. The second thing is that the delivery system and the procedure complexity is much higher with leadless pacemaker devices compared to the transvenous systems, which means more complications or more maneuverability during the procedure itself. And finally, sometimes if there is suboptimal septal pacing, the operator would opt to go either higher or lower within the septum, and this would result into more need for repositioning, which also is higher compared to the transvenous systems. And so if the device went more septal, There is now a potential for a direct mechanical interaction with the tricuspid valve, which was well described in the literature before, that the closer the device is to the tricuspid valve, the more chance there would be for worsening TR. If the operator opted to go more apical, which is what happens in practice, that they go more apical or to the free wall, now we have a higher chance for left ventricular desynchronization with time, and this would increase the chance for pacing-induced cardiomyopathy, especially if the patient is pacing dependent, and this can result into secondary tricuspid regurgitation. And finally, if the device is not where it should be, sometimes it could be in the papillary muscles, and this would directly ball on the tricuspid valve annulus and also cause the same TR. So this was from the literature confirming the biplane fluoroscopy is not that accurate in predicting the location of the device, and this was true for both leadless pacemakers and for the lead-based systems. So our implications is generally not to say which device is better than the other due to the limitations we had, but what we say is that future research in a prospective, well-controlled, randomized designs should first confirm those observations. If confirmed, they should investigate the mechanisms behind either the inaccuracy in the location or the progression of TR. This is especially true since in 2023 we have the first dual-chamber leadless pacemaker introduced, and now we have overcome the AV dysynchrony associated with single-chamber systems, which means that this could replace the transvenous dual-chamber leadless pacemakers in less comorbid groups, and we can do this before confirming the actual safety endpoints of the device. This is even more important since last August, the first leadless pacemaker system for left bundle branch area pacing was introduced. So this was 2 months ago, and the design of this device depends on an extended helix that goes from the base of the device and goes inside the septum to capture the conduction system in the interventricular septum. And I'm not sure if it is a good idea to do this, and we are not sure where the device location is. So to conclude, with the study limitations in mind, leadless pacemakers showed no significant advantage in our analysis over transvenous permanent pacemaker systems in preserving the tricuspid valve function, left ventricular ejection fraction, or reducing major adverse cardiovascular events. Prospective head-to-head studies with advanced imaging analysis should be performed to investigate for any potential device-to-valve interactions and guide more accurate device deployment before we proceed to the next era in leadless pacing. Thank you very much. Would be happy to have your questions.
Kerollos, a great presentation. So if there's no clinical outcome difference between the two procedures or the two types of the leads, why would you be interested in doing a clinical trial?
To confirm that this is actually the true observation, or because we have, it's just an observation, we have limitations, and the prospective trial would be more able to say what exactly happened. If there is a progression, what happened? Is it really because of inaccuracy in the location, or it could be some non-mechanical process that could happen across time, like the higher pacing burden resulting into more pacing-induced cardiomyopathy, in which case we should really question whether to give this device to those who are less comorbid, because once we implant the device, it's much harder than the transvenous systems to extract it. So if something is wrong, it would stay with this patient for like 10 years.
Thank you. Tell me about the incidence or prevalence of atrial fibrillation in both groups, because I can imagine that the leadless group might have more AFib than the others, and that might therefore impact the degree of tricuspid regurgitation.
Excellent point. And what we did in our extended analysis now for the full manuscript is that we checked the prevalence, and it was much higher with leadless, about 75% compared to 50% or less in the transvenous systems, which could be associated with a worsening. But in the micro group so far, we have checked if the atrial fibrillation predicted this progression, and it was not associated with like much more worsening compared to the other.
Excellent presentation, Kiro. I was just wondering if you could talk a little bit on why is as a non-implanter and as also a fellow non-implanter, I was wondering if you could talk about why it is so challenging to implant leadless pacemakers. Because when I'm thinking about it, I'm thinking a transvenous pacemaker, I'm having to navigate multiple leads in different areas of the heart. But a leadless pacemaker, I'm just simply putting in that lead. I know it's more challenging than that, but I'm just simply putting in this leadless pacemaker. So could you speak a little bit of why it's so challenging? And is it just the imaging portion? Or, yeah, wonder if you could speak more on this.
Another great point. So what I observed in the EB lab and from talking with our operators here is that the challenges is mainly both in that they are not sure where they are putting the device eventually from biplane fluoroscopy, and more importantly also the deployment system itself, like the delivery catheter itself is challenging to deliver the device easily where it should be compared to the transvenous systems.
Thank you so much. That was an excellent presentation. As you have indicated earlier, the indication for leadless pacemaker is acute infection where you cannot navigate a pacing wire through the transvenous system, and also like atrial fibrillation where you have given up the atrium, you're just focusing on the ventricles and implanting a pacer on the interventricular septum, and others vascular complications as well. I think the fact that the TR is not that much different in transvenous versus leadless pacemaker, that might be actually a good finding, supporting more leadless pacemaker where there is enough indication to go that route. What do you think of that?
Absolutely, that's an excellent point, and I guess the main point of our study is not to say that the leadless is comparable or worse than the transvenous in inducing TR. It's in saying exactly what you said. It could be due to baseline comorbidities, or it could not. There is a biological plausibility, as we discussed, as to whether if this is possible to happen with leadless pacemaker systems, and the answer is yes. And if the answer is yes, before we proceed to the next era in this and start to give it to less comorbid patients, telling them, oh, it will reduce your TR risk, we should be confident that it actually reduces the TR risk. Because what we have now from our analysis as well as from the literature is that we are not quite sure. All right. Thank you so much. Thank you so much.
Our next speaker is Dr. Maroun Chedid, who comes to us from the Lebanese University in Beirut and also as a research associate scholar at the Mayo Clinic, and is now an advanced a fellow in the advanced heart failure section. And I'm delighted to have you come and talk to us this morning about a regional partnership model for VA-ECMO initiation and transfer from remote centers using air medical transport. Thank you.
All right, thank you, Dr. Sharkey, for the introduction. So the clinical background for this project is that cardiogenic shock, especially following myocardial infarction, still has a very, very high mortality. We're talking about 50 to 70% mortality in the literature. And this is despite all the progress and the knowledge that we have regarding temporary mechanical support, including ECMO, Impella, and all the positive emerging data regarding these devices. And one of the main reasons why this is happening is that there's not enough centers that have this robust clinical experience with such devices, or even that have their own advanced heart failure program. And this is absolutely true in areas that are more remote or rural. And in our talk today is going to focus more on the Midwest or states like North Dakota, South Dakota, or even northern Minnesota. The time to a facility that's capable of doing temporary mechanical support or advanced heart failure is pretty big. And so we established this partnership between the Minneapolis Heart Institute at Abbott Northwestern Hospital with Bismarck Air Medical, which is one of the main, or maybe the only air medical transport facility that's located in North Dakota. And the goal of this partnership is to provide comprehensive training in all types of MCS to the people in Bismarck or part of Bismarck Air Medical. And this collaboration includes education through lectures that are held virtually every other month. The main responsible physician for this is Dr. Renowitz. There's hands-on simulation for the flight team, and this simulation is provided by our perfusionists, our technicians here at MHI, as well as a 24/7 cardiogenic shock hotline for consultation for VA-ECMO candidacy, as well as real-time management on patients who are already placed on VA-ECMO. So how does this work? First, let's say there's a patient in either of the Dakota states or northern Minnesota. This patient would be identified as a candidate for VA-ECMO because of cardiogenic shock. The transfer supervisor nurse who's here at MHI is notified about this patient through a specific phone number and hotline. Immediately, the supervising nurse will create a thread between the providers in the remote or the other institution and the advanced heart failure cardiologist who's on call here at MHI. And this kind of direct communication will facilitate management while the patient is still at their primary institution. And it will help guide the management or the management steps along the way. And once the patient is approved for transfer, then the transfer protocol is initiated. And this is a screenshot about the protocol that has been established. And this is a very unique protocol as it is very detailed. It's kind of a checklist in terms of which patients are candidates for transport and what criteria they should meet to be able to be transported. And just to summarize it quickly, patients need to be on 3 or less pressors. While on ECMO, they should have minimal ventilatory support. The patient should be obviously sedated, even paralyzed if needed. And they should always be accompanied by 2 units of blood while being transported. Additional guidelines that are required is that there's no active bleeding happening, and especially bleeding around the access sites. Their calcium, if it's low, it should be replaced, as well as the hemoglobin and blood gas are also available. And this is the Bismarck Air Medical Group. So Bismarck Air Medical, or BAM, would provide a critical care registered nurse with ICU or ER experience, along with a trained paramedic on the flight. And then the perfusionist from MHI would be present on the flight from Bismarck to here. And this is sort of the outcomes that we found. We've analyzed and studied 15 patients total. 80% of them were male. The median age was 60 years old. The indication, STEMI-induced myocardial cardiogenic shock, was the most common. Post-cardiotomy shock was the other 26%. ECPR was in 23% of the whole group. The average distance of transfer was 323 miles or 500 kilometers. The time to arrival, which means the time from initiation of the protocol to arrival to Minneapolis Heart Institute, including time for transport, ECMO initiation, and air travel, was 14 hours total. The time on ECMO was 94 hours, and the survival to decan was 67%. And the survival to discharge is 53%. Now, why is this important? Because when we talk about time to arrival, which is the 15 hours, this is not it's not interrupted medical care. It's all uninterrupted. Along these 15 hours, this patient is managed at the same time with the providers at the primary institution, as well as with an advanced heart failure cardiologist here at MHI. And there is always someone present in case any complication should happen or if any questions arise. And this is very important in terms of access to high quality centers, because this one is one of the main limiting factors in the progress in terms of mortality in cardiogenic shock. The survival to decannulation of 67% is a very promising number. It's higher than the average survival for patients with cardiogenic shock, which is about 50 to 60%. And the survival to discharge is also 53%, which is considered a good number considering all the travel that's happening. The main centers that we've received patients from are Sanford Medical Center in Fargo, North Dakota, as well as Altru Medical Center, Sanford in Bismarck, and then Aberdeen Center and Sanford Center also in South Dakota. This is real pictures of patient one patient who has been transferred to our institution. So as we could see, the BAM personnel are present, as well as the MHI team. The perfusionist in this case was Andrew, and Andrew was part of the flight as well. This was a 62-year-old gentleman in North Dakota who was celebrating a holiday at his neighbor's house, and he suddenly collapsed. Fortunately, the neighbor is an ER nurse, so she started CPR very quickly on him. EMS were called. He was transferred immediately to Sanford Medical Center in Fargo, where he underwent VA-ECMO, and he was a otherwise healthy 62-year-old guy. He was probably diabetic, but otherwise he had no major comorbidities. He was placed rapidly on VA-ECMO after consultation with our team for refractory cardiogenic shock, and he was accepted for transfer. He was transferred to us, and this is Roger before discharge. He did pretty well. He was on ECMO for 3 days total. He was on ECPella. He eventually required an ECPella 2 for 3 days total, and he was able to discharge back to North Dakota without any long-term complications. Thank you.
Questions?
So, very interesting presentation. So I assume that time is of the essence, right? So, would it be important to subtract traveling time, because the distance is whatever, you can't change that, but maybe you can, if you subtract traveling time, then the rest of the time is spent on procedures that maybe you can change, and then see if there's something you can do to decrease the time between the two, but the time to transfer someone.
So you mean the time to putting someone on VA-ECMO at their initial center? Is that the question?
No, at the traveling time, the transfer time. So you're transferring somebody, right?
Yes.
So you subtract the traveling time, because the distance, you can't shorten the distance.
Correct.
And is by helicopter or plane. And so the rest of the time is time spent doing paperwork or coding, or there are different procedures that maybe you could shorten.
Yeah, I mean, again, like 15 hours is, since the time of initiation of ECMO to arrival, is considered a very good time. It's not considered a very long time, especially that the patient is already on ECMO and they're already being managed in real time. It would have been very different if the patient required 6 hours in order to be on ECMO and then transferred here. But the rapid initiation and the real-time management during the flight makes it essentially like the patient is almost here in person, but they're even managed during the flight.
I assume in follow-up to that question that these patients were all revascularized urgently at the local center.
If required, yes.
Yeah, so the STEMIs all had reperfusion at that site, so the reperfusion was already.
And only 23% were eCPR, so those were the patients who ECMO was placed for CPR or during CPR. The remaining patients are patients who got admitted to their own hospital with shock, got revascularized, maybe spent a day in the ICU, and then they didn't improve, and that's why they were placed on ECMO.
Oh, I see. Okay.
And then another follow-up to that, is this just VA-ECMO or Impella patients excluded? How does that enter into the
So
equation?
our analysis only focused on VA-ECMO, but we also receive a lot of patients who are on Impella mainly if they have to put an Impella CP or 5.5. But our analysis was only for VA-ECMO patients.
How many or what percent do you get VA-ECMO versus Impella these days?
I think the majority is VA-ECMO. I don't have the exact number, but the majority of transfers are patients who have VA-ECMO. The Impella transfers that we get the most are from local areas, from local hospitals around the Twin Cities. But for this specific protocol with BAM is for VA-ECMO.
Thank you, Maroun. One of the humbling things to me with MCS is when we get people to decannulation and then they still don't make it to discharge. And so I'm wondering if you have, and certainly 15 patients and building, obviously, but if you have any intention in looking at what's happening between those, because we think we get the patient out of the woods, yet they don't get out of the hospital. Any interest in pursuing that?
Yeah, we did. We actually we have a paper that is submitted, and we're waiting for its publication about death after decannulation while they're still in the hospital before discharge. It's not specific for this group, but I assume that this group would also be some of these patients were probably involved in that paper too. The main reason is major neurological injury. That's the main medical reason, but the other main group of people is people who withdrew their care before discharge. And it's a little bit tricky to, in someone, for example, like this patient who otherwise never had any discussion about goals of care and suddenly, collapsed. It's very hard to, and especially that we're running against time here. So we usually initiate ECMO and transfer before we have this full discussion whether the patient wants to be on long-term dialysis, whether the patient had a major stroke or not. A lot of them will have the stroke here after the transfer. So yeah, those are the two main reasons. We didn't really look at it for those patients, but we are looking at that in general here.
Thank you. Thank you for that amazing talk. So I had two questions. One, did you say that our perfusionist flies back to Abbott with the patient, and how does our perfusionist get to North Dakota? And is that introducing a delay that could otherwise be mitigated? And the other question is, what happens with these patients' cardiac rhythm status? Are there ventricular arrhythmias that result in problems during transfer or after decannulation that we could focus on and do something about?
Yeah, of course. Yes, so the perfusionist is actually, they will travel from here to North Dakota through the Bismarck Air Medical. In terms of delay, it's not really a lot of delay because once the patient is qualified for transfer, our perfusionist immediately will travel there. So let's say it's a 2 or 3 hour travel. It's the exact time required to put someone via ECMO, to stabilize them, make sure that all the checklist is okay, and then the patient will be transferred. Considering ventricular arrhythmias, I think all the patients who had ECPR, their initial rhythm was VT or VF arrest. The patients who were decannulated, we didn't really find that ventricular arrhythmias were the main reasons for their mortality. And patients who have VT or VF while on ECMO are usually treated accordingly, either through ACLS or ablation if required.
Thank you. Next speaker is Dr. Mariam Desouki, who also hails from Egypt and has been a wonderful addition to our international scholar program on the 4th floor in electrophysiology, and has distinguished herself as being a great team player and involved in many projects. This morning, Dr. Desouki is going to speak to us on a rather lengthy topic for a Monday morning, ablation of atypical atrial flutter using a dual energy lattice-tip focal catheter and integrated mapping system. And welcome to the podium.
Good morning, everyone. Thank you for being here today. I am Mariam Desouki, an international research scholar in the Heart Rhythm Science Center. Thank you for the kind invitation. Today, I'm delighted to present our institutional experience of the ablation of atypical atrial flutter using a dual energy lattice-tip focal catheter and integrated mapping system. Thankfully, the engineers were kind enough to give it another very short name, which is AFERA. To begin with, I have no disclosures to declare. Let's start our presentation with a little background and the clinical rationale of our study. Atypical atrial flutter remains a significant procedural challenge due to several factors, including multiple prior catheter ablations, extensive atrial fibrosis, and complex reentry circuits that often involve non-tricuspid isthmus site. These patients usually present with advanced atrial remodeling that usually requires high-intensity mapping in order to identify and interrupt complex atrial arrhythmia effectively. Despite advances in technology, the recurrence rate of atypical atrial flutter remains high. Our approach uses an integrated ablation and mapping platform that eliminates catheter exchange. Our approach allows for high-intensity mapping with real-time temperature feedback and delivers both pulse field and radiofrequency energy using a focal tip lattice catheter. Bidirectional steering enhances precision and allows bidirectional steering enhance precision. This configuration provides procedural efficacy and improve operator control. Previously published studies have established pulse field ablation as an emerging source of energy when compared to radiofrequency ablation due to its high tissue selectivity. As we can see here, with a AFERA Sphere 9 catheter, we are able to create wide ablation lesion with a diameter of 9 mm with very limited collateral damage when compared to the conventional ablation catheter where a collateral damage to the surrounding structure is possible. The data specific to atypical atrial flutter within the literature is very limited. Therefore, we aimed to provide additional insight by determining the safety, intraprocedural efficacy, and short-term clinical outcomes of Sphere 9 catheter in the treatment of patients with atypical atrial flutter. This figure represents an overview of our AFERA cohorts of patients according to the type of atrial arrhythmia targeted during ablation. For today's focus, we would only discuss the subset of patients who had atypical atrial flutter. Our study cohort included 20 patients who presented exclusively with atypical atrial flutter, while the remaining 54 patients only presented with an overlapping arrhythmia substrate plus atypical atrial flutter. This is a single-center retrospective study. We included patients diagnosed with atypical atrial flutter, which is defined as atrial flutter originating from a site other than the tricuspid isthmus. They presented to our EP clinic from January 2025 to July 2025. Our procedural endpoint included fluoroscopy time, fluoroscopy dose, procedural time, and acute procedural success. Safety outcomes were assessed through the occurrence of major adverse cerebrovascular and cardiovascular events and acute kidney injury. In addition, we evaluated the recurrence rate of atypical atrial flutter beyond 3 months after the procedure. In order to better understand our clinical outcomes, we divided our patient group into ablation-naive patients, those who don't have any prior catheter ablations, and previously ablated patients who have undergone one or more prior catheter ablations. In terms of baseline characteristics, there was no significant difference between the two groups, except in BMI, where it was significantly higher in the previously ablated patients. We targeted a variety of flutters, including roof-dependent, septal-dependent, and perimitral. It's very important to highlight that the pulse field energy is exclusively used in 40.5% of the patients, while in the remaining patients, a combination of both pulse field and radiofrequency energy is used. As we can see here, pulse field energy was used with the majority of the flutter substrates, while radiofrequency ablation energy was only used in cavotricuspid isthmus flutter and the perimitral flutter, which is in close proximity to the coronary artery disease, the coronary artery. Sorry. In terms of procedural characteristics, procedural success was achieved in 99% of the cases. The integration of mapping and ablation into one catheter yielded an efficient workflow of median procedural time of 94 minutes and optimized the fluoroscopy exposure. In patients with prior radiofrequency ablations, acute procedural efficacy with sphere-9 catheter was 99% compared to 82% achieved in their prior radiofrequency ablation, showing a substantial improvement in acute procedural efficacy. When compared to outcomes reported within the existing literature, our results showed superiority in terms of acute procedural efficacy, which means that the seamless transition between ablation and mapping didn't compromise the lesion quality. Within 90 days follow-up window, 7 patients experienced recurrence of atrial arrhythmia requiring cardioversion. 5 of these patients had a history of at least one prior catheter ablation. In the majority of the cases, the recurrence represent an atrial arrhythmia mechanism which is totally different from the one who have been targeted before. Regarding safety outcomes, within 30 days post-procedure, there was no reported major cerebrovascular and cardiovascular events in our cohort. When comparing to the complication rates reported in the previously published studies, our complication rate lies within the lower end of the reported ranges, which support the procedural safety of Affera even in patients with prior catheter ablations. 46 patients had a follow-up duration of more than 3 months, out of which 5 patients, which is approximately 11%, presented with recurrent atrial arrhythmia beyond 90 days. Most importantly, none of them experienced the same atypical atrial flutter circuit. This figure demonstrates the electroanatomical mapping of a patient with roof-dependent atypical atrial flutter, which was refractory to multiple prior radiofrequency ablation procedures, and it was terminated with only one shot. This is the final pulse field ablation lesion set following the ablation, completely covering the critical isthmus. Here we can have a closer look at the intracardiac electrograms from sphere-9 catheter lens where the cycle lens is covered and the atypical atrial flutter is terminated. In conclusion, catheter ablation of atypical atrial flutter using Affera demonstrated a phenomenal intra-procedural success and excellent procedural safety. However, an extended follow-up duration with a larger sample size of patients patients is needed to determine the long-term efficacy in the reduction of atypical atrial flutter recurrence. It makes us wonder if Affera can simplify the most complex flutter, what it might do to the rest. Thank you, and happy to take any questions.
I'm wondering, thank you for that presentation. That was very nice. With respect to these atypical atrial flutters, there seems to be two distinct groups here, right? The ones that have native atypical flutter and then the ones that have had a previous ablation procedure. And I'm wondering, because the numbers are small, it seems like the ones that have had a previous ablation must be quite different than the ones that have not. And do you have any thoughts about long-term follow-up in that subgroup? Or maybe, John, you have some comments about that as well. It seems to me as a cardiologist that deals with people that have had a previous flutter ablation and then have recurrence, that the post-ablation patients are a unique subset.
Thank you, Dr. Sharkey. This is a great question. When I went through the charts of these patients, 6 months after, or 3 months, 6 months after, because with Affera, it's new technology, as you know, we just have a very limited follow-up duration right now. But all the atypical atrial flutter targeted were terminated. The recurrence was with atypical atrial flutter from a different circuit. And as the atrium has very advanced fibrosis, very advanced remodeling, which make it vulnerable to have another substrate of atypical atrial flutter. And I know our sample size is very limited, but when we had a comparison in terms of the baseline characteristics in patients who are ablation naive and patients who had previously ablated, previously ablated, there was no difference in baseline characteristics except in terms of BMI, which is actually another point, that if patients do not control their lifestyle and not reduce their BMI, still there would be a recurrence afterwards, even with Affera, which is, logical, because like it is what it is, that was, yeah.
Comments from the electrophysiology world?
Yes, Miriam, thank you so much for that excellent presentation. And finally, some good news for patients with recurrent atypical atrial flutter. Your figures were excellent, and the mapping that you saw represents a real leap forward, because in that particular picture, there's a high density map of the left atrium. Obviously, there's been prior ablation. You can see the right-sided pulmonary veins there. This is on the right side of the screen in the left-sided map, are isolated. They're black. There's no voltage there. The left-sided veins have voltage and activation, but there's a clear roof-dependent flutter. And this was mapped with the Affera catheter, and then immediately you can transition to ablation. Say, we're going to fix that, put a lesion there, terminate that flutter circuit, and then remap and see, is there anything else to fix here? Regarding the issue of recurrent arrhythmias after ablation, it's been a problem for, forever. Early on, there was an exuberance for the stepwise approach, which was pulmonary vein isolation, try to reinduce atrial fibrillation. If there's recurrent atrial fibrillation, then consider placing linear lesions. And that has been a problem since the beginning because of the problem of recovery of tissue after radiofrequency ablation, in that if you have the roof or the posterior wall where you have the esophagus as potential collateral damage, you can't deliver high energy, you can't deliver long lesions, you have to be careful about collateral damage to the esophagus. With PFA, there's no risk of damage to the esophagus. So suddenly, we're back in a position where, hey, we can isolate the posterior wall. That prevents roof-dependent flutter. It gets rid of a lot of that substrate that has been infiltrated with fibrotic islands of fibrosis that can result in recurrent arrhythmia. So we make the posterior wall quiet, and then if we need to put a roof line or a mitral line, to eliminate perimitral flutter, we can do it with a high degree of surety that our linear lesion set is going to be durable indefinitely. And that is something we haven't had for 20 years. So we can do that now, but we would shy away from placing lines previously because any gap in a line guarantees you're going to need another procedure. So that's why this is a big step forward. And I think you elucidated that very well. Thank you, Mariam.
Thank you very much. And our final speaker this morning is Matthew Katsianis, who is a research associate coordinator here, has been with us now for what, 2 years, Matt?
Last summer and then now 3 months.
Yeah. Okay, so close enough. And Matt hails from Minnesota, of course, and we're going to have him talk to us about the significance of peri-device leak detected by CT tomography after a percutaneous left atrial appendage occlusion. Welcome.
Thank you. I'll just add this first. Okay. There we go. Okay, well, good morning, everyone. Thank you so much for being here. Thank you, Dr. Sharkey, for that very kind introduction. And before I get started, I just want to say that I can't emphasize enough how much of an honor it is to be given this opportunity to speak today. I also think it's very unfair that I have to go after these three incredible researchers. I know it was alphabetical order, but come on, A, C, and D, I think that's very unfair. Anyway, as Dr. Sharkey said, my name is Matt Katsianis, and I'll be presenting on the significance of peri-device leak detected by cardiac computed tomography after left atrial appendage occlusion. I have nothing to disclose. So left atrial appendage occlusion is a stroke prevention procedure in patients with atrial fibrillation who cannot tolerate long-term oral anticoagulation. Now, this is a minimally invasive catheter procedure using the Watchman device with the goal of sealing off the left atrial appendage from the left atrium. Now, there are other devices that are used for this procedure. However, the most commonly used one is the Watchman device, and that's what we'll be focusing on today, or what we focused on in our research. So why do we want to occlude the atrial appendage from the atrium? Well, patients with atrial fibrillation are 3 to 5 times more likely to suffer a stroke compared to patients without atrial fibrillation. Now, this is due to that loss in coordinated atrial contraction that can move the blood flow through the heart. Without this, the blood can become stagnant and pool in the atrial appendage, where clots can then form. Then these clots can leave the atrium, migrate to other areas of the body, and in particular the brain, and cause patients to suffer a stroke. Now, due to this, patients are typically prescribed anticoagulation, or otherwise known as blood thinners, but patients have a lot of reasons why they can't tolerate these blood thinners. One of the main ones being a high risk of major bleeding. And so for these patients, atrial appendage occlusion is an option for them. Now, immediately after their procedure, patients are still expected to remain on short-term oral anticoagulation for around 6 to 12 months. And ideally, the device will completely endothelialize and completely stop the communication between the atrial appendage and the left atrium. Now, this is an ideal scenario. However, this does not always occur. And so some major limitations to the procedure are device-related thrombosis and peri-device leak. Now, due to these major limitations, 45-day post-procedure imaging is an essential portion of left atrial appendage occlusion. Now, historically, this is done via transesophageal echocardiography, or TEE, but recently, cardiac computed tomography with angiography has evolved as a sensitive and non-invasive tool for the assessment of left atrial appendage occlusion devices. And recently, CT is increasingly being used as this follow-up imaging tool. Now, this is for several different reasons, but the main one being that CT allows highly detailed 3D images without the discomfort and sedation requirements that TEE typically comes with. Now, in this post-procedural imaging, physicians are looking for 2 primary things, the first being device-related thrombosis. So is there any thrombus forming on the Watchman device itself during this 45 days post their procedure, as well as peri-device leak? So peri-device leak, as I stated, is a widely known limitation to this procedure, and it can come in many different forms. Oh no, the cursor's not working. Anyway, as shown in this figure to the right. So one of the most commonly observed forms is the edge leak, which I was hoping to use the cursor, but it's that top left one. This is where there's still communication between the left atrial appendage and the left atrium along the edge of the device and the cardiac tissue. And now peri-device leak has been shown to be fairly common and can occur in up to 32% of implantation. And this is very concerning because several studies, like this large meta-analysis, found that peri-device leak was significantly associated with almost a 2-fold increased odds of thromboembolism. It also found that it was associated with an increased all-cause mortality. And now this especially is very important because left atrial appendage occlusion is a stroke prevention procedure in patients. We're looking to prevent something that might not actually occur in these patients. So peri-device leak really has the potential to undermine the therapeutic benefit that left atrial appendage occlusion is supposed to bring these patients. Lastly, the current guidelines on what we should consider a significant size or not of peri-device leak is very arbitrary. And although I just showed that meta-analysis in the previous slide, data on the association between peri-device leaks and thromboembolic events is sparse and contradictory. There are just as many studies that say peri-device leak is not associated with thromboembolic events. And specifically, most importantly, in the last published clinical practice guidelines just in August, when they talk about peri-device leak, they still would not specify a significant size. So this is where our research begins. So we were looking to answer what is the association of peri-device leak of any size as detected by CT with major thromboembolic events post left atrial appendage occlusion. So this was a single system multi-center retrospective study of patients with a clinical indication for left atrial appendage occlusion who underwent a successful Watchman implantation and underwent a CT post their implantation. Our primary endpoint was any major thromboembolic events, such as a composite of stroke, TIA, or systemic embolism. And our secondary endpoint was device-related thrombosis. We then conducted a pairwise comparison between patients whose CT revealed peri-device leak and those whose did not. So we included 100 patients in our analysis with a median age of 77 years. Their median CHADS-VAD score, which is their risk of stroke, was 4. The median HAS-VAD score, risk of bleeding, was 3. CT was performed with a median of 57 days, where we found a peri-device leak incidence of 22%, with a median size of 4 millimeters, and a device-related thrombosis incidence of 4%, with a median of 2 millimeters. Only 9% of our patients suffered the primary endpoint. So now in our pairwise comparison, we did not find any significant associations between patients with a peri-device leak and a well-seated device, except we found a modestly higher or significant association between patients with a peri-device leak on CT and device-related thrombosis on CT. So out of the 4 patients who developed device-related thrombosis, 3 of them also had a peri-device leak on CT. So as I stated previously, only 9% of our patients suffered the primary endpoint, but something we did want to point out in our outcomes was the still high rates of major bleeding in these patients. And now, yes, these patients are getting a Watchman device mostly because of their high rates of bleeding, but we believe that this could have something to do with, surprisingly, these patients still remaining on oral anticoagulation despite receiving a Watchman device. So this is something that we are still looking into today. And lastly, I wanted to share this table because when I gave this presentation in Spain, a very kind cardiologist from Poland, he came up to me after the presentation. He really was curious he wanted to know, the patients who developed device-related thrombosis, what oral anticoagulation were they prescribed after their procedure? And I thought this was an excellent point. So as you can see, from the 4 patients who developed device-related thrombosis, 3 of them were prescribed an oral anticoagulation. But interestingly enough, the patient who developed the largest thrombus, while only 0.8 of a millimeter, was actually prescribed dual antiplatelet therapy, or clopidogrel and aspirin. So this is another thing we are looking into as well. As common in research, the results from this study has given us about 10 more ideas to keep researching. But still, there was still no significant association between device-related thrombosis and our primary endpoint. So this study was limited by its small cohort size of only 100, its retrospective design, as well as only including patients from a single system. But we concluded that peri-device leak of any size as detected by CT was common after left atrial appendage occlusion. Peri-device leak was not significantly associated with higher incidence of thromboembolic events. However, there was a significantly higher incidence of device-related thrombosis in patients with peri-device leak. And lastly, I just wanted to acknowledge the amazing researchers on this slide, in particular, Dr. Jason Gupta and Dr. Ali Baba, as I couldn't have asked for kinder and better mentors into this whole world of research. And then I did want to give a shout out to Dr. Hamid and Dr. Cavalcante, as they took time out of their very busy schedules to come support us in Spain. And then Dr. Hamid took us out for some paella as well, because we were in Spain. But with that, if anyone has any questions, I'd be happy to answer, but thank you so much for your attention.
Thank you, Matt. That was excellent presentation. One observation that you pointed out, which is very interesting one, was higher bleeding in patients post the left atrial appendage Watchman device. And it's not surprising to see some patients either in clinic or in a hospital setting where they had Watchman placed and they're still on apixaban, and they don't know why, and somehow like there is some miscommunication or no clear communication between the implanters and the subsequent follow-ups. I think that's a very excellent area to focus on and see how is the follow-up, and also like clearly to follow the guideline and stop those anticoagulations, because that was the whole purpose of putting the left atrial appendage closure device to begin with, and that's a very excellent observation. Thank you.
Thank you so much, Tesman. I 100% agree, and that's something that we're trying to look into, is what these patients, they're receiving the Watchman, and then I'm seeing that we're looking at the outcomes for, because a lot of these, we're looking at patients who received in 2016, and I'm seeing in their charts to this day, they're still on aspirin or clopidogrel. And it's just there's reasons for this, but it's something we definitely need to look into, because the whole point of receiving the Watchman device is these patients have a very bad history of being on anticoagulation. So we need to figure out why they're still remaining on this. But yeah, thanks, Tesman.
Sort of a follow-up to that and to your Polish doctor, cardiologist friend. Did you examine the anticoagulation profile of those patients that had major bleeding and look and see how it might have differed from those?
So another excellent point, and that was something when I was making this slide of what we should have done. So that is an excellent point. That's definitely something we need to look into as well, because from my history of looking into a lot of these charts, I will say that a lot of times, especially in this patient that was on dual antiplatelet therapy, I would not be surprised if they had an extreme history of major bleeding events. A lot of these patients, there are some that have none, there are some that have one GI bleed, and then there are some that have recurrent GI bleeds that they just can't, that they simply say, I'm no longer, or they will be prescribed anticoagulation, and it'll say in their chart that they aren't taking it because of this reason. So that would be my prediction there, but this is definitely something that we need to look into.
Well, I think you've exposed a really important opportunity for improving patient care, and to your point as well. Other questions? John?
Nothing on my.
Just a quick comment. The decision about antiplatelets and anticoagulation therapy of any kind is like infinitely nuanced in any individual patient when you're the primary clinician making that decision. And I think in patients like this, who we know are high bleed risk, they're high ischemic risk, and then 22% of them have a device leak, you're basically just reinitiating a shared decision-making conversation with the patient, and it's totally reasonable that some of them may stay on anticoagulation for a myriad of reasons unrelated to atrial fibrillation. Some of the, and like you said, 22% have a device leak that were very unclear on the data. So, you're talking about a patient who's just bled, who's had a stroke, who had a Watchman placed with a 4 mm device leak. You may decide to continue anticoagulation with the patient because a recurrent stroke may be of more morbidity to that patient than a recurrent hospitalization for bleed or something. So just to kind of get at the nuance, it's really tough to make those decisions at the point of care with the patient.
Totally, yeah, no, thank you so much. I mean, and that's kind of goes back to this paper on the right, the clinical guidelines, is they still, when they're addressing what we should do to address peridevice leak, they don't have a recommendation because it is so nuanced, and then there's hardly any research into this area. And even when there is, they're very contradictory. One says they should remain on anticoagulation, the other says no. So I 100% agree. It's a very challenging area.
Great. Thank you.
Yeah.